Ever had that really weird feeling? Your fingers or toes, they go beyond just chilly, you know?
Yeah.
Like they turn properly white, maybe even blue, and feel completely dead. It's a strange one.
It really is.
Well, today on the deep dive, that's exactly what we're getting into. We're tackling Raynaud's phenomenon. What is it? And why does understanding it tell us so much about how our body signals things?
That's the plan. Think of this as, well, your high-yield guide to Raynaud's. We've taken the key stuff from revision notes, and we're aiming to make it clear, memorable.
Right.
The goal is really to take what can seem like dry medical facts and make them stick, make them understandable. We'll cover everything from the definition right through to potential complications, focusing on what you really need to know.
Okay, great. So these episodes, the icy fingers and toes,
Yeah.
what's the actual definition of Raynaud's phenomenon?
Okay, so at its core, Raynaud's involves these episodes of vasospasm.
Vasospasm.
Yeah, basically the tiny blood vessels in your fingers, toes, sometimes even nose or ears, they suddenly constrict, they narrow really intensely.
Ah. And this clamping down, it causes that classic sequence of color changes you mentioned. First, pallor goes white because there's no blood flow.
Right.
Then, cyanosis, it might look bluish because the trapped blood loses its oxygen.
Okay.
And finally, as the blood flow returns, you often get redness, maybe some swelling, and usually this comes with numbness, tingling, sometimes even real pain.
So it's much more than just feeling the cold air. It's something actively happening in the blood vessels.
Exactly. And a really, really key point here is the difference between primary and secondary Raynaud's.
Okay.
Primary Raynaud's, sometimes called idiopathic, means these episodes happen on their own. There's no other underlying medical reason we can find.
Right.
Secondary Raynaud's, that's when these symptoms are actually caused by another health problem.
Got it. So primary is just the Raynaud's, secondary is Raynaud's plus something else triggering it.
Precise.
Okay, so what actually makes these blood vessels spasm like that? What's the etiology, the cause? Well, for primary Raynaud's, the general idea is it's an exaggerated, sort of over-the-top response to cold temperatures or even emotional stress.
Mm-hmm.
For some reason, these triggers cause a much more intense narrowing of the blood vessels than you'd normally expect.
Okay.
Now, secondary Raynaud's, that's where things get a bit more complex because it's linked to quite a few underlying conditions.
Like what?
Think autoimmune disorders, things like scleroderma, where you get inflammation and vascular issues. That's a big one.
Scleroderma, right.
Also, rheumatoid arthritis, lupus SLE, those can be involved. Even some blood cancers, like leukemia, can be linked. And then there are conditions like type hyperglobulinemia and cold agglutinins, which involve proteins reacting to cold.
Wow, that's quite a mix already. Anything else that can cause the secondary type?
Yeah, definitely. Using vibrating tools for a long time, like jackhammers or certain factory equipment that can actually damage the small blood vessels.
Ah, occupational hazard.
Exactly. Also, certain medications are implicated. Some types of the oral contraceptive pill, drugs containing ergotamine,
Ergotomy, okay.
and more rarely, a physical thing like a cervical rib that's an extra rib up near the neck can sometimes press on blood vessels or nerves and trigger Raynaud's symptoms.
Okay, so it seems like some people are just more prone to this. What are the risk factors for developing Raynaud's?
Good question. For primary Raynaud's, being female is a big one. It's much more common in women.
Right.
There seems to be a genetic link, too, so a family history makes it more likely. Living in a colder climate naturally increases exposure to triggers.
Makes sense.
And as we mentioned, things like vibrating tools or certain chemicals, that exposure can be a risk factor, too, though that obviously overlaps a bit with the secondary causes.
Right. And what about the red flags? What clues might make you think, this looks more like secondary Raynaud's?
Yeah, this is super important for catching those underlying conditions. Several things should raise your suspicion. If the symptoms start later in life, say after age 40, that's a key one.
After 40.
Okay. If the symptoms are mainly on one side unilateral, we call it, that's unusual for primary.
One side only. Interesting.
Also, the presence of skin rashes, finding specific autoantibodies in blood tests, those antibodies that attack your own body.
Right, the autoimmune markers?
Exactly. And any features that suggest something like rheumatoid arthritis or lupus joint pain, maybe recurrent miscarriages. Other warning signs are digital ulcers, little sores on the fingers or toes, and calcinosis, which is where calcium deposits form under the skin. Oh, and rarely chilblains might be a clue too.
That's quite a list to keep in mind. Is there an easy way to remember those specific risk factors for secondary causes?
There is. Mnemonics are great for this. Try remembering 4 rash DC.
4 rash DC.
Yeah, so 4 from onset after 40, R for rash, A for antibodies, S for RASL features. H is actually for unilateral symptoms, kind of cheating the H, but it fits.
Okay, unilateral.
D for digital ulcers, and C for calcinosis. 4 rash DC, hopefully that helps lock those in.
That's really helpful, thanks. 4 air, rash, DC. Got it. So let's go back to the basics. What's actually happening physiologically during an attack? The pathophysiology.
So the fundamental issue is that abnormal vasospasm we talked about.
Right.
Those small arteries in the fingers and toes, they just constrict way too much, way too easily when they're exposed to cold or stress. It means there's some kind of dysregulation in how blood vessel tone is controlled.
Like the normal balance is off.
Exactly. The balance between constriction and relaxation is messed up. The autonomic nervous system, the system controlling all the automatic stuff like blood pressure, vessel diameter, it's definitely involved. And again, this whole process can be the main problem itself that's primary, or it can be a consequence of some other disease messing with the vessels that's secondary.
Okay, clear. Now, if someone comes in with these symptoms, the color changes, the numbness, what else might be going on? What are the main differential diagnoses we need to consider?
Crucial point. You absolutely need to rule out other things that can cause similar symptoms. Peripheral artery disease, for instance, PAD, where arteries are narrowed by plaque, that can cause coldness and color changes.
Okay, PA.
Embolic disease, where a blood clot travels and blocks an artery that can cause sudden dramatic changes.
Right, and embolism.
Various types of vasculitis inflammation of the blood vessels themselves, they need to be on the list. And obviously, if someone's been exposed to extreme cold, you have to consider frostbite.
Makes sense. And you listed quite a few secondary causes earlier. Can we break those down a bit more, maybe by specialty?
Sure. So from a rheumatology or autoimmune angle, the big ones are scleroderma, SLE, lupus, rheumatoid arthritis. Also things like dermatomyositis, polymyositis, Sjogren's syndrome, less commonly Pachyoses arteritis, giant cell arteritis, even primary biliary cirrhosis.
Okay, that's the rumen.
Then you've got arterial and vasospastic disorders. Things like arteriosclerosis, hardening of the arteries, Berger's disease, Prinzmetal's angina, which is spasm in the heart's arteries. And even migraines can sometimes have peripheral vasospastic features.
Migraines, too. Interesting.
Endocrine or metabolic causes could include carcinoid syndrome, pheochromocytoma, hypothyroidism, diabetes. And then there's a sort of miscellaneous group. Other vasculitides, carpal tunnel syndrome, arterial thromboembolism, cholesterol emboli lodging in small vessels, thoracic outlet obstruction, and reflex sympathetic dystrophy, or CRPS.
Wow, okay. That really drives home how many things could be underlying secondary nodes. Let's try an example to make it stick. Say a 45-year-old patient presents episodic finger discoloration. What specific things in their history would make you lean towards secondary Raynaud's?
Great example. Okay, 45-year-old, new finger discoloration. Well, first off, the age. Onset after 40 is a big flag for secondary causes, as we said.
Right, the 4 and 4 rash DC.
Exactly. Then, if they said the symptoms were only in one hand, or maybe much worse in one hand, that unilateral feature.
Unilateral, right?
And definitely asking about other symptoms. Any new joint pain or stiffness, any skin rashes they've noticed, unusual fatigue, dry eyes or mouth. Anything systemic like that strongly suggests an underlying issue, likely autoimmune. And of course, if they happen to know they have positive autoantibodies from previous tests, that's a major pointer too.
That makes perfect sense. So how common is Raynaud's actually? What's the epidemiology look like?
It's actually quite common. Estimates in the UK vary, but somewhere in the range of 3% to maybe 20% of the population might experience it.
That's a pretty wide range.
It is, yeah. Likely depends on how it's defined and surveyed. But it's definitely much more common in women. And the peak age for primary Raynaud's to start is usually between 15 and 30.
Younger onset for primary.
Right. And the good news is primary is much more common overall. Maybe 80–90% of cases are primary. Secondary Raynaud's makes up the other 10–20%. We know the triggers. Cold is the big one. Sudden temperature changes, stress, some meds, injury, vibrations, smoking, underlying artery disease.
The usual suspects.
Pretty much. Primary tends to show up in the teens or 20s, while secondary is often linked to those connective tissue diseases like scleroderma, which might appear later. Oh, and there's an interesting study in school children in cold climates found about 18% of girls and 12% of boys had symptoms, and it got more common in girls as they got older.
18% of girls. Wow, that's quite high. So clinically, what does it actually look and feel like during an attack?
So the classic picture is this color changes we keep mentioning. White, then blue, then red, usually in the fingers or toes,
Right, blue, red.
triggered by cold or stress.
Yeah.
And patients often feel pain, numbness, tingling, pins and needles, that kind of thing.
And the sequence is always white, blue, red.
That's the textbook sequence, often starting with pallor, maybe sparing the thumb, the numbness, pain, the blue cyanosis phase, and then the red reperfusion phase as blood flow comes back. But honestly, it can vary. Some people might skip a color, or the order might be slightly different. The key is the episodic nature and the link to triggers.
Okay. And how do you start to tell primary from secondary just by talking to the patient and examining them?
Well, age and sex give you a clue. As we said, younger women, more likely primary. Then you really dig into associated symptoms, and those risk factors, remember, FURSDC.
Got it.
A key thing is what happens between attacks. Someone with primary Raynaud's, their hands and feet often look completely normal when they're not having an episode, no other signs.
Nothing to see between episodes.
Exactly. But with secondary Raynaud's, you might find other clues during an exam. Maybe abnormal pulses, signs of heart issues, skin thickening or changes, swollen joints, maybe enlarged organs, or rarely signs suggesting malignancy.
So the absence of other findings between attacks points more towards primary.
It does, yeah. And just a quick memory tip for the phases during an attack. Think PCR, P for pain, C for color changes, R for reperfusion redness.
PCR, pain color reperfusion. Nice. Okay, so diagnosis is mainly clinical history, but what investigations might be done?
Right, history and exam are key, but tests help confirm things and, crucially, look for secondary causes. For a young, otherwise healthy person where you strongly suspect primary Raynaud's, you might just do some basic screening bloods, like maybe a full blood count, FBC, check inflammatory markers like CRP or ESR, plasma viscosity, and an anti-nuclear antibody test, ANA. Often these will all be normal in primary Raynaud's.
Okay, basic screen.
Yeah.
What if you do suspect an underlying cause?
Then you need to investigate more thoroughly. That could mean kidney and liver function tests, UNEs, LFTs, thyroid function, more specific autoantibody panels looking for markers of lupus, scleroderma, etc.
Right, digging deeper.
You might check blood glucose for diabetes, look at proteins in the blood or urine, test for cold agglutinins, check fibrinogen levels, and maybe a chest x-ray if you're thinking about something specific, like a cervical rib.
And you mentioned something earlier about looking at the nail folds.
Ah, yes, capillaroscopy. That's really useful if you suspect secondary Raynaud's, especially a connective tissue disease. You use a special microscope to look at the tiny capillaries in the skin at the base of the fingernail.
What do you see?
In primary Raynaud's, they usually look normal, meet loops. In secondary Raynaud's, especially with scleroderma, you might see enlarged capillaries, areas where capillaries have dropped out, or little bleeds. It can be a strong clue.
I see. Are there other specialized tests?
In secondary care, yes. Things like infrared thermography to map temperature, laser Doppler flowmetry to measure blood flow, portable radiometry, digital plethysmography. These give more detailed info about blood flow dynamics, but aren't usually needed for initial diagnosis.
Okay, so summing up the differences based on investigations and clinical picture.
Sure. Primary. Typically younger female, no signs of underlying disease or tissue damage like ulcers, normal nail capillaries, normal ESR, negative autoantibodies.
Right.
Secondary. Can be older onset, often other symptoms or signs present, maybe digital ischemia or ulcers, abnormal nail capillaries, possibly raised ESR, often positive autoantibodies pointing to a specific condition.
Okay, that distinction is really clear. So once you have a diagnosis, how do you manage Raynaud's?
The main aims are, well, firstly, to reduce how often attacks happen and how severe they are. Secondly, protect the fingers and toes from cold and potential injury. And thirdly, if it's secondary, treat the underlying condition.
Makes sense. What about non-drug approaches?
Lifestyle stuff is absolutely fundamental. Keeping warm is key, not just hands and feet, but the whole body. Managing stress, avoiding known triggers like sudden cold exposure, maybe certain medications if they're contributing.
And if that's not enough, medications.
Yeah, if lifestyle changes aren't sufficient, medication can help. First line is usually calcium channel blocker like nifedipine. These help relax and widen the blood vessels.
Nifedipine, okay.
For more severe cases, sometimes intravenous infusions of prostacyclin analogs like ipraprostanol or elaprost are used in hospital. These are potent vasodilators and can sometimes give longer periods of relief.
Right. Any specific advice just for primary Raynaud's?
For primary, the single most important self-help measure is stopping smoking. Smoking massively constricts blood vessels.
Crucial.
Then all the cold avoidance advice, good gloves, maybe heated gloves if needed, hats, scarves. Be aware of vibrating tools if that's relevant. Topical nitrates like nitroglycerin cream have been tried, but the evidence is a bit iffy.
Yeah.
Systemic drugs like neftapine are the mainstay if needed, and those IV prostaglandins like iloprost for more severe primary cases. Surgery is really a last resort for very debilitating symptoms. Things like arterial reconstruction, sympathectomy, cutting specific nerves, removing clots, cleaning up ulcers. But cervical sympathectomy isn't generally recommended anymore.
Got it. And for secondary Raynaud's, the focus shifts a bit.
Absolutely. For secondary, job number one is treating the underlying cause. Get the lupus or scleroderma or whatever it is under control.
Right.
But importantly, even with good control of the underlying disease, the Raynaud's symptoms might not completely go away.
Ah, okay.
So all those general preventative measures, keeping warm, avoiding triggers, are still vital. And because connective tissue diseases are so common in secondary Raynaud's, referral to a rheumatologist is usually standard practice.
When should a referral definitely happen?
Definitely refer immediately if there's severe ischemia, like critical lack of blood flow, signs of impending tissue loss. Also, refer all suspected secondary cases for investigation. Any child with Raynaud's should be referred. And if symptoms are really severe, not responding to initial treatment, or if you suspect an occupational cause.
Okay, that's clear. What's the long-term outlook typically like? The prognosis.
For primary Raynaud's, it's generally pretty good. Symptoms are often mild, manageable, and interestingly, some people actually go into remission. Symptoms can disappear in maybe up to a third of people over 7-14 years.
Oh, really? They can just stop.
Yeah, symptoms can fluctuate with seasons, stress, and sometimes seem to get better with age. Now, in a minority, maybe around 13%, an underlying disorder does eventually show up years later, but most primary cases stay stable.
And secondary.
Secondary Raynaud's, the prognosis is much more tied to the underlying condition. These patients are generally more likely to develop complications. For example, in systemic sclerosis, as we mentioned, about 17% might get digital ulcers, scarring, or even gangrene.
That really highlights the importance of catching secondary causes.
Yeah.
Which brings us to complications. What are the main concerns?
So the main worry is that if the vasospasm is really severe or goes on for too long, the lack of blood flow can damage the tissue.
Right.
Thankfully, serious complications are rare, but they include those digital ulcers, the painful open sores, and in very rare, severe cases, gangrene, which is actual tissue death. So it's really important if someone notices skin breakdown or if the Raynaud's is really impacting their life, they need to seek medical advice promptly. Getting the right management can help prevent these things happening.
And prevention is key.
Yeah.
Remind us of the top prevention tips.
Definitely. Avoid smoking, number one. Avoid medications known to trigger it if possible, like beta blockers. Wear warm gloves, hats, layers, heated gloves can be great. Maybe consider warmer climates if it's really severe and feasible, and avoid prolonged use of vibrating tools. Simple things, but they make a difference.
Great. This has been incredibly thorough. So to wrap up, what are the absolute key takeaways about Raynaud's phenomenon?
Okay, key points. It's about episodes of vasospasm causing those color changes, white, blue, red, usually in fingers and toes. Crucially, distinguish between primary on its own and secondary due to another condition.
Right.
Recognizing the features that suggest secondary Raynaud's is vital for finding and managing potentially serious underlying diseases. Understanding these things is key for managing it well.
Absolutely. And that leads to a final thought for our listeners. Given that huge range of possible underlying conditions for secondary Raynaud's, what do you think is the single most important initial question to ask a patient presenting with new Raynaud's symptoms?
That's a great question to focus the mind. I think perhaps the most important first question, beyond clarifying the Raynaud's symptoms themselves, would be something broad like, beyond your fingers and toes, have you noticed any other new or unusual symptoms anywhere else in your body recently? For example, any joint pain or stiffness, skin changes like rashes or tightness, unusual tiredness, dry eyes or mouth, or anything else that's new for you.
Casting a wide net for systemic clues right away.
Exactly. It opens the door to exploring potential systemic causes from the very beginning, helping guide whether you're likely dealing with primary or secondary Raynaud's.
Excellent point. Well, that's all we have time for on this deep dive. For anyone wanting to reinforce this knowledge or prepare for exams, do check out passthemsra.com and also freemonraynaud.com. They're fantastic resources. Thanks for joining us.